Well, good evening. Thanks to all of you that were able to join. My name is Mike Bolognesi. I'm an orthopedic surgeon at Duke University, and I'm honored to be serving as a moderator for this special session. This Grand Round session I'd like to introduce is thanks to the Park City Hip and Knee Foundation, which was established in 2015 to help exchange orthopedic knowledge. The next phase of our educational efforts with this group were events like this. And so they're designed to be accessible, free to residents, fellows, and industry who want to learn. And with that, I'd like to move on to our slides here to start the session. And again, I'm just the moderator. You saw our topic, impact of technology on efficiency, and it's just a great group. And we're going to start off with Steve Murphy from New England Baptist, David Mayman from Hospital Special Surgery, Rand Schwarzkopf from New York Langone Orthopedic Hospital. And I believe Rand might be our only attendant or panelist that's going to give two talks. And so with that in mind, I'm going to go ahead and pass the mic to Steve Murphy, who's taught me a lot about acetabular component position, and I'm sure he'll do a great job tonight. Thanks so much, Murph.
Thanks, Mike, and thanks to the foundation. My job is to talk about patient-specific planning and rapid, accurate component placement. Here's some disclosures. The main one is that I've invested in a navigation company, which I'm talking about today. So the three biggest problems I think we're facing in hip replacement are cup malposition, leg length discrepancy, and fracture. And what I'd like to do is describe a method that we think can address all of these in less than 1 minute of surgery time. How do we do that? Well, this is patient-specific, knowledge-based. We study the spine-pelvis relationship, femoral anteversion. We know where the pelvis is functionally in space in preoperative imaging. We can plan and place components accurately and instantly assess leg length change in surgery. The patient-specific intelligence is based on images being uploaded. And so in addition to functional radiographs, we also have a CT study, and we can do sitting and bending films as well and incorporate those into our concepts. And then once we've done the planning, we give that to the surgeon who can run the application on any machine, Mac or Windows, Windows tablet, touchscreen computers. And in addition to the software, there are patient-specific smart tools that are adjusted for each patient to accomplish the cup alignment goals, and I'll show you how leg length is measured as well. The way this works is the image information is uploaded, and the CT is the main thing for the 3D planning. So there's a model of the pelvis and a model of the femur, and then we have libraries of component sizes that we decide what sizes, what positions, prediction of leg length change, and the settings for the smart tool to accomplish the planned task. And again, we can use any kind of functional information, and if we learn more about what we should be doing with spine-pelvis relationship and motion, we can incorporate that at any time. And the surgeon is free to change the plan however they want based on their own personal preference or any information they have locally that we don't have through the web. And this is just typical multi-planar imaging. We know which implant, which surgeon wants to use, and so we just plan the cup accordingly. And the same with the stem. We know the native version, we know the planned version that we're aiming for. There's 18 different stem systems in the library, and we have every neck offset, neck length, and head combination, as well as all the liners for all the cups. These are just typical 3D models that are in the library. So in the OR, the surgeon gets the plan. They can just put the plan up on a regular big LCD screen in the OR, or you can run it on a touchscreen workstation or a touchscreen laptop. Or in this case, Windows 10 tablet will run, and you can just use it as a simple touchscreen navigation system in the OR. So it's quite convenient because these are very inexpensive and they're easy to use, and you can adjust the plan on the fly. either before or during surgery. In terms of leg length, the way that it works is we know the implants and we know the neck lengths and the head. So if we plan where the tip of the trochanter is in 3D on the patient's bone model, and we know the shoulder of the prosthesis on that actual CAD file, and we know the distance that the surgeon is measuring in surgery, then we can predict the leg length and offset change quite rapidly. This is literally only about a 10-second event to calculate leg length and offset. And if we look at that scientifically, it's within 1 millimeter of accuracy on average, and the biggest range is 3 millimeters off, which over a large group of patients is quite good, especially considering the simplicity. In terms of intraoperative cup alignment, there's a smart tool for any of the laterally positioned surgery exposures, and another one for supine. And we think this one can really reduce the number of x-rays that you need because you know component positioning, and especially in terms of fracture risk. We don't have evidence to prove it, but we really think that if you know exactly what implants you're supposed to be using and what will fit and what won't, that we will be able to eventually reduce the risk of fracture as well, hopefully. Accuracy, Mike's colleague Sam Wellman did a study a few years ago, very complex cases. Tim Randell was on that study too, he's talking later. And 54 hips, every one within the target range, even considering some of these were spectacularly complicated cases. And that's in fact more accurate than the common robot that people use. In terms of time efficiency, this is one of my colleagues at New England Baptist. Incision to begin closure time was 4 minutes longer on his learning curve, and it got down to less than 1 minute total OR time difference. And we think that obviously it takes a few minutes to use, but he's sped up by the fact that he knows what his issues are, what the component sizes are going to be, and what the femoral version issues are, where the osteophytes are, and what he's going to be facing. So it speeds him up, and the net time is not statistically different at all between using the tool and not. Comparing it to other technologies, certainly compared to robotics, it's way less expensive, it's way less time consuming, it's much more accurate. And you can see this study, a tremendous number of outliers with a robot, which is a huge issue still. Just too many moving parts and too many sources of error. In terms of the non-image-based cases, not having patient-specific information really limits technology. And if you look at image-free tracking systems, whether they're optical or accelerometer, they have trouble registering the pelvis, and there's no guarantee that the beginning position of the pelvis on the table has anything to do with the functional position of the patient after surgery. And some of these systems, one in particular, only had 70% of the cups in the right range in any version. So they have a lot of trouble with registration, knowing where they are, and with accuracy. So in summary, we do think that in less than 1 minute of OR time net, you can get a very accurate cup, you can get very accurate leg length, and we hope we can solve some of the fracture problems as well.
Steve, that was great. We're obviously going to have some time to talk in the end, and thank you for staying on time. It's impressive to do. I've told these guys I'm going to hold them to task on the time, so we have opportunity for questions. So please use the Q&A box. Now, Dave Mayman is going to talk to us about handheld navigation. Yep, again from HSS in New York. Thanks, Dave.
Hey, thanks very much, Bo, and thanks to Park City Foundation as well. You know, one of the things when I was asked to do this talk, and I saw the agenda, that I loved seeing is every talk on here is about using technology, but still being efficient in the operating room and not doing things that are adding extreme cost or time to surgery. So I think that's a really key point that I think everybody's going to make during these talks today. In terms of disclosures, I'm a consultant for Smith & Nephew. I've got stock options in Orthline and a company called Imagen, which does some imaging, artificial intelligence stuff. And I will be talking about Orthline in here in this talk. So when we talk about a simple accelerometer-based navigation system, through its development, there were some very strict ground rules, and they were ground rules to make sure that it was something that surgeons would want to use. So if we look at those ground rules, first of all, no large console navigation system that needed to be in the room, no large capital equipment investment. Hospitals just don't want to spend money on this stuff. Everything needed to be part of the surgical field. So we wanted everything right in front of us, sterile in the surgical field, so we didn't have to look outside the field or touch anything outside the field or have somebody non-sterile address anything outside of the field. No line of sight issues. Anybody that's used robotics or large console navigation systems know the issues with line of sight issues and either not being able to see the arrays or assistants having to duck out of the way while holding retractors in order to be able to see things. And just as important as all of the rest was keep it simple, make it something that surgeons would actually want to use. And if we think about what we're doing with navigation in hip replacement, for the large majority of hip replacements, the acetabular component position is important, but it's not important to be accurate within 1 degree. We need that acetabular component to be close. We don't want to see an x-ray post-operatively that surprises us. And leg length is critical. No patient comes into the office and says, hey doc, my acetabular component's at 46 degrees of inclination, and I read somewhere that it was supposed to be at 43 degrees. But they do come in and they say that my leg feels long, and that's something that they continue to complain about. And really, we don't want post-operative surprises, and we don't want the need for intraoperative imaging. Over the last several years, there's been a big push towards intraoperative imaging, especially with an increasing use of direct anterior approach. And we tried to do something that would take intraoperative imaging out of the operating room. So I'm going to go through a bunch of images. And these images are really to show you how simple the procedure is. It can be done either in the lateral position or the supine position. I think today, any technology, it's important that you can use in both of these positions for hip replacement. Patients set up the way that they're normally set up. I do a posterolateral approach. This patient is set up lateral on the table. This is how we prep and drape. If you look close, there's actually a plate it's just an ioband that's holding this on the leg here. You'll see why we have that in a second. And then I've drawn out my incision just off the back corner of the greater trochanter. So 2 pins go into the iliac crest. So 2 vertical pins go into the iliac crest to hold the device in place. There's a clamp that goes onto those 2 pins, and then the accelerometer-based system is here. There's one part that has a battery in it that is non-disposable and one part that's disposable. And then there's a laser that actually aims at a target on the leg. And that's just so you can put the leg back in the same position every time you measure for leg length and offset. So the first thing you do is you have to register the pelvis. And as Steve said, and I'll grant him this absolutely, this depends on your pelvis being level when you start the case. So I always check on the position of the pelvis before we prep and drape. This isn't something that I let an intern or a resident or first year resident, second year resident position the patient. I always check on the patient. You'll notice that we do the registration of the pelvis before we make an incision, before we do exposure, where you're going to have retractors in, people pushing and pulling the leg so to change the position of the leg. And you can see I'm holding this bar, this arm, along the plane of the body. So this is adjusting for pelvic tilt. So when we look at it, so this is really giving us functional anteversion or functional position of the pelvis. So after that, we do our standard exposure. And then after your exposure, we mark a spot on this little plate here, which is just the spot that the laser points at. And the reason for that, again, is so that you can put the leg back in that position every time you check leg length or offset. And then there's a little tack, a little checkpoint that goes in the greater trochanter. It's a single checkpoint that goes in the greater trochanter. You put the probe into that point. You push a button on the device here, and it registers the initial leg length and offset. Then the device comes off. You keep the clamp that's just still on those pins. The device comes off, and you go ahead and you prepare your acetabulum the same way as you would normally prepare your acetabulum. So it's very comfortable to surgeons that haven't used any sort of navigation before because you're reaming the acetabulum as you normally would. You then start to put your acetabular component in. So there's an acetabular insertion handle here. There are threads for every brand of acetabulum. So this is implant agnostic. You can use whatever implant you want. And I start by putting my implant partway in, so just a couple of taps, just so it gets a little snug in the acetabulum. And at this point, I'm looking at my bony landmarks, transverse acetabular ligament, putting that acetabular component where I think that acetabular component needs to go. And the way I teach the residents and fellows this is really what you're doing is you're putting that acetabular component in to get a good solid bite in the acetabulum, tucked under that anterior wall so you don't get iliopsoas impingement in the position that you think the acetabulum needs to be in. And then the device is to check. The device is to make sure that you don't mess up the position that you're putting the implant in. So the device goes back on the clamp, you push a button that's basically saying, hey, are you set up to measure the acetabulum? And then you move this battery-powered part from the device here onto the acetabular insertion handle when it gives you the green light to do that. And then it gives you real-time acetabular component position. So it gives you inclination and anteversion, both in the functional pelvic plane. So you can see in this case, this acetabular component is at 38 degrees of abduction and 25 degrees of anteversion. Okay, and then I think it's always important, again, we're surgeons, you can't just depend on this technology. You need to be able to look at what you're doing. So look at that acetabular component position. Again, making sure that the anterior metal part of the acetabular component is tucked under that anterior wall. You're typically going to see a little exposed acetabulum, superior and posterior. You can use your transverse acetabular ligament for guide as well. So you're putting that component in where you think it fits in that patient's pelvis, and then you're checking with the device to make sure that there are going to be no surprises. So then we move on to the femur, and this is just standard femoral exposure for a posterior approach. I use a ream approach system, so this is me reaming here. This is a trial broach in place, and you can see we're about to do a trial reduction here. And then once you do that trial reduction, you reposition the leg. So the laser that's on here, again, you position the leg so that it's pointing at that point that that crosshair that you've marked on this plate down here. You put the probe back in that checkpoint, you push a button on the device, and it tells you where you are compared to where you started. All right, so it tells us in this case, we've lengthened the leg by 3 millimeters and we've increased the overall offset by 2 millimeters. And then you look at your preoperative plan and decide how much did you want to lengthen the leg? Do you need to adjust it? Is this appropriate for this patient? So simple to get leg length and offset. So we've got some data for both posterior approach and anterior approach. The posterior approach is HSS data, so myself and a number of other surgeons using the device at HSS. This study was just over 300 patients. The inclination average angle was 41.6 degrees, and postoperative radiographs measured at 42.9. Again, those are averages. The standard deviation is a little greater than that. The standard deviation was about 3.5 degrees. So it's not a device that you expect to be within 1 degree. And anteversion angles were 22 degrees on the device versus an average of 23.6 degrees measured. Again, standard deviation is about 3.5 degrees. 77% of cases were within 1 millimeter for target leg length, and standard deviation was just under 2 millimeters. So really quite good or excellent in terms of leg length, and very good in terms of acetabular component position. If we look at anterior approach, and this is just an image of anterior approach and how you use the device for an anterior approach. Here we saw inclination angles 39 degrees with a standard deviation of 4.6 degrees. Now, these non-navigated numbers were with fluoroscopy. So really what this shows is that this device, a handheld accelerometer-based device without any fluoroscopy for anterior approach, was equal to a non-navigated with fluoroscopy, both for anteversion and for inclination. And leg lengths were within 1 millimeter of expected in 57% of patients, and within 2 millimeters of expected in 79% of patients. So I think really quite good results, both anterior and posterior approach. Thanks very much.
Dave, that was great. Enjoyed the talk as always. Rand, who again we've tasked with 2 talks, is going to be the last talk of this session, and he's also talking about navigation for total hip. It's a high-tech approach. So thanks, Rand. We'll pass it on to you, buddy.
No problems. So this is again another navigation system, a mini navigation system, and everything that Dave said, I echo. All of the things about it needing to be easily placed, line of sight, not expensive, small amount of disposables, not slow you down. They're all equivalent in this system as well. The relevant disclosure that I'm a paid consultant and I have stocks in this company that does this navigation system. So we all know the problem. What is the safe zone? And we're not going to go into the hip, spine, and all the other functional safe zones that we talked today, but we're starting to have an understanding where each patient should have their cup placed, leg length, and offset. And then the question is, what's also the best place for where? The minute we combine this and we have a good preoperative planning, we know where we want to position this. So for a navigation system, you want it to be suitable for primary and revision. And one of the biggest uses I use this system is in revising cups, and I'll talk about it during the video. It has to be compatible with all the approaches, open platform for all the system, and I personally think it should be imageless. I don't think we need high-tech imaging like CT and MRIs to do this. I do think that X-rays have to be integrated into the systems in the future, because the same as Dave presented, there is one inaccuracy in some of the systems that we tell it where the pelvis is in space. And I think in the future, we'll be able to merge it with the imaging. So looking at that workflow, no significant OR time added. And I managed to even get my my chairman, Dr. Zuckerman, to use this. And if somebody has been doing hips for 30 years, make him use the new technology and from now use it for all of his cases, it just tells you that the technology, when it's doesn't add significant, the learning curve is small, and potential for implant trials and reduction goes down, you can get any person to start using it. The same as Dave showed, cup position less than 3 degrees with the standard deviation, leg length within a millimeter, offset within a millimeter. And during the video, I think I'll explain a little bit in the next pictures about leg length and offset when we talk about it. One of the biggest things we found when we started using this, that patients roll on the table. And if you look at the old ways we used to do the hips, we aligned it to the wall like we did our knees. And we found that when we examined using the navigation, after we put the pins and we put the camera, the accelerometer, we then measured in the end of the case, patients roll. And they can roll on the bed a significant amount that can affect significantly that position of the cup. So if you're putting the cup in relation to the table or the room, like the classic old ways where you don't use technology, when the patient shift on your positioner, you're going to put the cup in a malposition. That goes away. Again, you want to have one tray, a limited amount of equipment to use. This is the navigation system. This is the same pins on the pelvis, a camera, and that's a tabular handle with an array that sits on top of it. That's me in the operating room doing the same thing. As Dave said, I put the cup in, I put it where I think it should be with the anatomical landmarks, the other things I thought, and then I check. I look at my inclination, I look at my anteversion. And sometimes you are surprised and you notice that the patient moved. You get a number that doesn't match what you thought it is, and then you look at the system and ask it to tell you how much did the patient shift, and you see the patient move 10 degrees on the table. And I think that's very important. So you get the inclination, you get the anteversion position, and then you can do it on your trial, you can do it on the real cup, and then you can take it. After that, you can get the leg length and the offset. So when the problem with leg length and offset, if the system takes the position of the leg in neutral and then it measures it back to how much you changed, that means it built a plane in the position, and that plane may not be the same plane that you use after you did the hip. If you added anteversion to the original neck, that will change and move millimeters from length to offset. And that's what the posterior thing is here, because that tells you that there is a shift in anteversion. And we are able to look at these images during the case, and you can see that the stem has been added anteversion, and that anteversion will be translated maybe as a loss of offset, because the offset is measured in the previous plane. So this is something to think about as you use technology. You have to understand what the technology tells you in the language it's speaking to. And then you get the kind of summary that gives you everything. Another useful thing that I use is the center of rotation. Let's say you put a cup and all of a sudden it tells you the center of rotation is lateralized. you should think that maybe you did not take all the osteophytes out and you put the cup to lateral. And that's another advantage that you can get from using these systems, things that it's harder to get without technologies. So let's look at a quick video of me doing the case, and I can talk you through it. So the way I operate, that my fellow is starting to do the incision. After I see that he cut the skin in the right place, I'm the second pair of hands putting in the 2 screws. I like to work simultaneously. I put 2 screws on the crest while the exposure is being done. And the 2 screws are very stable. There's no issues with that. It's the same similar to what Dave showed in most systems that have to use something on the crest. And like this, we can work simultaneously. And there's no movement at this point. I'm not afraid the patient would shift. I usually like to finish the basic stuff before we start dislocating the hip. And this is after the exposure. You can see the base plate. I already established the base of the camera and the navigation. This is a troch plate that sits on the troch itself. And you can see now with the overlaid image, we put a little screw in there to give more support. There's a short one, there's a long one if you think that the bone is soft or it's a very big patient. And now we do all the capturing. And this is maybe a little bit quicker than real time. You can see the speed my hands are going. But overall, it does not take a lot of time. So now we tell the system, this is the table, this is the position. Now I have to tell the system where the pelvis is. That's that rod. I align it with the anterior pelvic plane. And in the future, we'll align it with x-rays. And that will give more accuracy a little bit. At this point, we give us the basic level. So now that was the offset in length based on the plane that I dictate to the system. Now we do a center of rotation of the hip. And after we do center rotation of the hip, we're done. I do one more step. I put this and calibrate this probe because I use this probe to touch 3 points on my trials because I like to see where my trial sits to give me an idea where everything is. So now we did the operation, we reamed, and now that's what I'm doing. I have a trial in there, and I touch 3 points on the trial, point 1, 2, and 3, and it will give me the position of that trial. Then I have in my mind's eye where I want to put that cup. It's easier for me to look through a trial than look through the real cup, and I like the position, and then I go in with that acetabulum itself. And you can see the camera comes on and off. It's on the field. There's no line of sight. We're operating from both sides. There's no camera that's sitting on top. The camera goes into the pouch on the side. Every time I need to use it, I bring it back up. So now I trial, and a lot of times I will still use the antenna or the A-frame with my fellows and let them try and understand how to put this without navigation, then look if their guess was correct with the navigation. Because I think we have to be careful to teach our fellows and our residents just to operate with technology because they may be in a place where they don't have it. So I'm happy with the position of the cup. And now we're doing the same thing on the femur. We broached, we reamed. Now we're going to trial the femur. And this is, again, posterior approach. You can use the system in any approach. I do a small posterior approach, the same as Dave has showed. And now after we reduce the hip, before I put the camera, before I get looking at the leg length and offset, I always do stability. I think we should never forget to do manual stability. Even if we use navigation, it tells us the leg length and offset is perfect. You can still have an unstable hip. So don't forget to do stability. So after we reduce, we have to capture the new hip center. That's what we're doing. You see the camera is back on the field. And now again, you can see length, offset. I'm not that happy. I'm going to do another trial. We're going to change the head. And then we got the planned length. Patient was short a few millimeters, so we compensated. We got a few millimeters longer. We got the offset back, put in the real head, and then you can capture the overall length and offset for the end of the case. And at this point, I clean my wound with betadine. While the betadine is sitting, we have something to do. We take out the pins. We take out the little base plate on the troch. Don't forget things in the patient. It's never recommended. And we take that out. And then we have our summary, we have our x-ray, and we have the little summary page that I save for every patient, and we have those numbers. So that's it. Thank you.
That's great. Thanks, Rand. What I was going to do is I'm going to start with Murphy, if that's all right. And Steve, you said something during the talk that I think was very, very interesting, because I think it's becoming more and more of an issue, this fracture issue and planning with your, the system you use and trying to avoid fracture. I think it's very interesting now, particularly some of the work you've done with the Medicare claims data and looking at fracture and other large databases, which particularly in our elderly patients, the use of press fit stems and fracture concern. And I just want to get your comments about sort of that importance, you know, and maybe it's one of these things we haven't realized how valuable that might be.
Well, we looked at the Medicare claims data, and we found that if you include operations around the hip, not just revisions, but all reoperations, 45% of reoperations around the hip in the first year for fracture. And so that's certainly the biggest problem. And it's about over $100,000 per patient if that happens. So it's a big problem, and certainly leg length doesn't require repeat surgery, but it can but problems with leg length can lead to very unhappy patients. Patients don't know if the cup is malpositioned unless it wears or dislocates, but those are the three big problems. In terms of fracture, we do think that we can help surgeons avoid problems if you know what size will fit, if you know what size won't fit, if you know how far inside the trochanter it can go. I think if people get some experience, you know how far you can push the femur and when you should stop. And so we think that with a little bit of experience and some study, we'll be able to identify that having knowledge about component sizing and depth will be able to improve a surgeon's ability to avoid fracture without undersizing.
Thanks. I got Dave, question for you too, and because I maybe put you a little bit on the spot here, because I've seen you talk very nicely also about a robotic approach, and I know you've used a lot of different technologies. Is there a specific patient that maybe you use a case like this over a robotic platform? Because again, I know you have facility with them with more than one technology.
Right. So, you know, I've played with all this tech over the years, and I think each piece of tech kind of has its place. So I have used robotics. I still use robotics for some of my hips. I think the best case for a robotic total hip is a very complicated acetabulum. So a patient with bad hip dysplasia, getting that CT scan, and you know, Steve may want to comment on this with his system as well because he has a CT scan preoperatively.
Yep.
But a CT scan, you get that preoperative plan, you know exactly where the cup needs to go, and then sometimes you get into these cases and it's tough to see where you want to ream, and the haptic control of the robotic system just puts your reamer in exactly where you want to ream. So it takes some of these very difficult acetabular cases and makes them quite straightforward. Now, I don't think that you need a system that's that complicated, that expensive, and that cumbersome in the operating room for a straightforward primary total hip replacement. So I think each technology has its place.
Yeah, Rand, for you, I was sort of going to ask a little bit about your utilization just in general, and if I missed it during talk, I apologize. What about for you? What percentage, say, of your hips are you going to use this approach? And I missed it if you said, meaning using the device, the technology.
I didn't. I use it in 100% of my cases now.
But I thought, I just wasn't sure. I wasn't sure.
I use it also in revisions. There's some revisions I don't, like periprosthetic fractures or things that I'm not changing the cup, or I think that where I'm doing the stem, like infections or first stages, or cases that like that, I may not use it. With the inaccuracies of the navigation, because we are telling it where the pelvis is, both me and Dave, when you do a revision for an acetabular cup, the delta difference of when you change a cup to a new position, especially for patients that have instability, is 100% accurate, because it doesn't matter so much what the number it gives you, it's the difference in the number. And that's always accurate. And I find it very challenging to change a cup 10 degrees just without the technology, because by the time you take out the old cup, you don't remember where it was exactly, and the landmarks are there, and how do you know you're actually putting the real cup, the next cup where you want it? So I think technology there is like a magic tool. Since I've been using it in those revisions, the cup is always where you want it when you come out of the revision.
Got a question for all of you, I guess, or everybody can comment from the participants, and it's asking about if you're using these for intraoperative accuracy. You know, are you using them, or why not always use them for collecting or validating final placement of cups? And maybe going through them, might just make your comments about if you use them for final placement validation, or why you, I guess, give us your take on that one. I don't think I'm reading that right. Does that make sense?
So I think the question is, we do validate our cup. We know where our cup is placed. The thing is that the cup is placed depending to what the system is. Then we validate it with X-rays, because again, we told it where the pelvis was, and we may have made a mistake or something like that. So that's why the validation is done with X-rays afterwards. And both Dave and I presented that we validated this system and we feel comfortable with the results they give us.
Yeah, so the one thing I'll add, with hip replacements, I feel like the more we learn, the more we don't know. So when I started, asked to have the component position, 40-20, those were the numbers we were aiming for in every case we did. And as we've learned more about the spine and the pelvis and the relationship and what happens when patients move into different positions, we see that there is no one static position of the acetabulum. So part of what we struggle with a little bit now is I can measure a position in the operating room. I can measure a position direct to the anterior pelvic plane if I want to, but the position I measure on an X-ray is very dependent on the patient's position in the X-ray. So when you get somebody standing versus somebody sitting, some people stand with a little rotation of their pelvis. Some of this stuff changes from preoperatively to 1 year postoperatively. So you'll get a series of X-rays on the same patient, and acetabular component position will be measured differently on each of those X-rays because the pelvis was in a slightly different position. So I'm not sure that saying intraoperatively this was my position and on an X-ray this was my position is really a valid way to measure acetabular component position. We want to make sure we don't have wear, although with cross-linked poly, wear has become a much less of a concern. We want to make sure that we don't have impingement. We want to make sure that we've got a stable hip joint, and we want to make sure that we don't have soft tissues that are wearing over the front of the acetabulum and giving you pain. And that's why I think we don't want surprises on the acetabulum, but that 1 degree of accuracy on the acetabulum I don't think is critical.
Steve, I was going to just ask you to go back, because as I understand, to maybe comment a little bit in line with what the guys were just talking about, particularly about pelvic plane and position, because I know in some of your work with Sam, I think some of the planning that is proposed back after the CT scan goes in does attempt to take into account some of that, at least as much as you can, again, with the static CT image. Just get your thoughts sort of on that issue.
Yeah, we look at patient-specific issues. We look at supine pelvic tilt. If we get the information, we also get standing pelvic tilt. We plan cup goals on a patient-specific basis. So if somebody has a negative pelvic tilt, we'll flatten the cup, and if they have a lot of pelvic lordosis and positive pelvic tilt, we'll open it. And we do that in proportion to the degree of the abnormality. And then flexibility, I think with spine pelvis stuff, the abnormality of the tilt tells you where the center of your goal is, but the stiffness of the spine doesn't tell you anything other than your safe zone is narrower than it would be if it weren't a stiff spine, but it doesn't change the goal. The goal is changed by the position of the pelvis functionally, which we can measure in more than one position. But in terms of registration accuracy, this kind of a smart tool is a self-registering instrument, so that as long as you dock it correctly, you know that it's accurate. And when you have all this patient-specific information, including CT, we can measure accuracy compared to the goal, because you can take a lousy X-ray and measure the exact angle of it using 2D, 3D matching, and then calculate the real cup position compared to what you aim for. So we validated the accuracy of the instrument with any number of studies, including post-op CT as well as 2D, 3D matching. So if you put the tool on correctly, it is very tightly accurate, which helps especially with stiff spines, because you don't have to bail to a dual mobility hip if you know where you're going. I think the problem with instability, as these guys showed with stiff spines, is if you don't know exactly where you want to go and you can't get there, a stiff spine can get you in a lot of trouble. But you can tolerate a stiff spine pretty well if you can decide exactly where to go and get there.
That's great. I'm gonna. We've got about 3 minutes. And this is a good question to let you all give a quick comment just about cost. It's cost in general, disposable versus purchase. I know you guys know a lot about this, but I think the real question is, what are your thoughts about, you guys are cost conscious guys too. You understand all the cost issues. give us sort of your take on costs. I know you're supporters of technology, but also aware of sort of where we are with the health system, so to speak.
I think all the three technologies that we've shown here don't carry a capital cost. I think all of them
are, I think that's where I'm trying to lead you.
Yeah, are all cost per case, and they're probably very equal among them, especially in the institutions that we work in. And I know all of them also have models of capital purchase or yearly subscriptions or something, but it's something very negotiable, and they're not extremely expensive compared to other technology. You're not buying $1 million robot for it.
Guys, Mayman, Murphy, anything else?
Is that you're paying on a case-by-case basis for the most part. So we've all seen the navigation systems that are bought by a hospital. Somebody convinces them to buy a navigation system. They get used for a little while. People get frustrated with them. The technology gets old, and then it sits in the back hallway of the operating room and never gets used again. And the hospital has had to pay a large fee for that. With all three of these technologies, if the surgeon uses it once, they pay for the one case. If they use it 300 times a year, they pay for either some subscription or per case amount. But if it doesn't get used, you don't have to pay for it.
That's great.
Yeah, I agree with David. There's no capital equipment for the system I described either, and the cost of it is about what the disposables for a robot case would cost, let alone the extra 10 minutes of OR time at sort of $50 a minute or whatever you want to put on that. And that's all before you get to pay more than $1 million for it to begin with and sterilize all the instruments. So the value is infinitely better and the accuracy is better too. So it doesn't make a lot of sense to try and do it the other way.
Well, thank you guys. We're coming up at the end of this group, and I just want to say, you guys, you really did a great job of, particularly for the CME event, giving a balanced, in three different technologies that, that are obviously competitive. You guys did a good job of doing it in a very fair way, a very balanced approach, it's not always easy to do. So I credit you guys, but we know you guys are all great speakers and very bright. Always learn a lot about cup positioning around you three guys. So I appreciate it too. We are going to move on to our next sort of session, and Rand does not get to go very far at this point in time. So the rest of the members of this group will be Tim Randell, who was referenced earlier, now down in Alexandria, Louisiana. Orhun from Boston is also on our panel. Probably needs no description or introduction. And of course, I can't say he's the guy that traveled the furthest, but my good friend Stefano Bini is joining us from California at UCSF and will be our last speaker. So there's 4 speakers in this next group, with Rand starting off again, this time speaking to us about navigation for total knee and not total hip. So Rand, thanks for staying with us here.
And no problem. So again, my disclosures, and the relevant one is IntelliJoint. The system also belongs to IntelliJoint. It's similar to the hip. It's the system. This one is much newer and in much fewer hands has used it until now. So I'll tell you a little bit of my experience. So again, the navigation with the knee is not something new. We had navigation in the knee for years, and it never managed to penetrate, I think, more than 10% more or less in knee surgeons. I think most of it because it didn't make a lot of difference for the patients. It took longer. You had that big camera in the room. You couldn't operate freely. Even though that, you still had 10%. In some countries like Australia, there's a much higher use of that technology. So I think the basics for navigation for knee are very similar to the hip. It has to be an open platform, easy integration. You can do the femur or tibia first. You can do your knee the way you want to do it. And again, it has to be imageless, minimal learning curve, and it should not add time to the OR. So this system, we started using it not too long. We did a study in our hospital, 3 surgeons, each one did 20 cases. And you can see the varus valgus, less than 2 degrees variance, flexion slope, less than 1, and the resection within 2 millimeters. Each one of the 3 surgeons uses the system a little bit different, where they put the pins and how they utilize it. I'll present the way I use it. Again, it's one system, disposable, or basically the screws that you use are the arrays, and it's the sleeve you put on the camera that's sterile. Those are your disposables. So this is an image of how it looks. You can see the camera. You can see the arrays. I'll show images of me with it. This is when you're about to cut the femur. And here's a picture of me in the operating room. I'm telling the sense, so I put the pin, and you'll see it in the video, into the femur. My idea and where I like to put the pins is where I would put the rods in the femur and the tibia, nowhere that will lead to any new stress or any new hole that would not have been there anyway, or I will do it by doing the keel and the tibia and so forth. So again, you can see here, this is the registration. Here I'm placing the distal femoral cutting guide. I'm looking at the cuts, I'm looking at my flexion, my valgus, what am I accepting, and now the same thing I'm doing on the tibia. I use my regular cutting guide on the tibia. You can see the pin on the tibia sitting in the ACL footprint, going down where the keel will go, so there's no added stress. And the camera you'll see in the video is mostly held by one of my assistants in their hand. It's not even fixed to any point. You can see here the summary page of the flexion, posterior slope. I've been adding more flexion in some of my Asian population. So let's look at the video. I think you're gonna have to start it for me. So the female, kind of a standard osteoarthritis, not very severe, a little bit on the obese side. This is my plan for the patient. 0 varus valgus, posterior slope. I'm a CR surgeon, so I add slope around between 7, try not to pass 10. So the workflow in the beginning is the same approach, expose everything. This is the kind of the video of the camera. We're selecting femur, tibia, which one you want to do first. I do femur first. I finish my femur. I'm a measured resection surgeon, so I finish my femur and then I do my tibia. So that will be the flow that you'll see here in the video. So after I'm done with my exposure, instead of where you usually go on the medial side for the intramedullary, I put it on the lateral side because I have to place my marker and show the center of the knee. So I can't put my pin where I have to tell the system or put the marker on. So this is the only point in the case where the camera has to sit stable. So it's sitting on a Mayo stand. We do the center of the hip. In a lot of navigation systems and accelerometer systems for the knee, this can be a little bit frustrating. The reason why it can be frustrating, because sometimes the pelvis moves. So if the pelvis moves, the system goes back to 0. So that's the reason it sometimes is frustrating, especially in big patients or stiff patients that have hip arthritis. So I'm telling the system where the center of the knee, where the AP line. Now we're going over the condyle, so where's the most distal point on the medial and lateral condyle for our planning. Now we're going to place the distal femoral cutting guide. I'm the surgeon that's holding it. I like operating from the other side of the knee. My assistant is standing on the lateral side. I'm actually standing on the medial side, so you guys won't be confused. So now I'm looking at the system. I put one pin, and at this point I just try and grab the flexion. With one pin, I grab the flexion, and from my experience using it, I usually grab it a little bit higher than what I wanted, because as I put the other pins, I tend to lose a little bit of the flexion. There's just the way that happens when I do it. So I learned from experience in a few cases what's the sequence, and you can see now I'm happy. At this point, I can take the pin out. We're done with the femur. I cut the distal femur. Now I just work with my regular instrumentation, and I finish the femur. I finish my 4-in-1 or 5-in-1 cut, depending on the implant I use. And at this point, I move to the tibia. So the tibia, I put the pin in the ACL footprint, just a little bit away from where I want to tell the center of the knee is, where I want to tell the system the center of the knee is. You put the array. At this point, I'll have to move my retractor that retracts the patella, because I like my assistant stands on this side. If you operate on the opposite side, then you can probably leave all the retractors, because the camera will be on the other side of the knee. Again, I tell the axis of the tibia is, because this will influence the slope. So you want to tell the proper axis of the tibia, highest point on the lateral, highest point on the medial. Now I like to use my regular cutting guide. Some of my colleagues will use the cutting guide that comes in the system. I place my cutting guide, I put it with the depth and position where I think I would go, and now I check it. I use the navigation to verify that I'm not in varus or valgus, to take away all those extremes on each side of your graph. And when you look at all your cases, I look at my posterior slope, I put my 2 pins. The depth of resection, don't look at it too much, because I can see I put my array on top of my cutting guide, because if you put it in the slot's usually a little bit wider and it's a little bit wobbly in there, because our slots get wider with time because we pass it many times a saw in it. So it takes a little bit of the metal material away. So now I still do all my manual checks. I don't trust the navigation by itself. I want to teach my fellows and residents to use the regular instrumentation and then use the navigation to verify it. If I would operate alone without teaching, probably I would take away a few of the steps. That's the workflow. You finish cutting. These are the post-operative x-rays, and you can see the summary page for this patient, and this goes in their file or in their chart if you want, and I save all of them. I think the navigation system I use on all my cases. I've never used navigation in the knee prior. I was a non-navigated surgeon. Now I use it on all the cases. I'm very happy with it. It's quick. It doesn't take more than a couple of minutes in my operating room, and it takes away all those extreme cases. Thank you.
Thanks so much, Rand. Another great talk. We're going to stay on this knee navigation sort of space, and Tim Randell, my good friend, is going to talk to us about handheld navigation. Hey, buddy, hope you're doing well. Looking forward to hearing you talk.
All right. Well, we're going to talk about handheld nav of the knee. Thanks Park City Hip Knee Symposium. Thanks Bolo for inviting me to do this talk. I really appreciate it. All right, disclosures. Do some consulting and training education Ortholine. I'm going to do a little talking about Ortholine. Also consultant with TJO and Stryker. So we heard all this already. We know where we want to put implants in. We have goals set, and if we fall outside of those goals, that there's a higher failure rate when we fall outside of our goals, regardless of if we're doing mechanical or kinematic alignment. Looking at navigation with the knee, we kind of hitting some topics again, but you know, there's large console navigation with and without imaging. Then there's this handheld nav, what I'm going to focus in on today. And the biggest pros for navigation is improved accuracy and precision with component placement. And the long-term cons would be operative time, blood loss, and cost. So accelerometer-based navigation, the biggest benefit would be decreased operative time compared to a console-based navigation. There's minimal additional operative time compared to the conventional techniques. Like we talked about earlier, the cost is relatively low compared to the bigger systems in robotics. And there's no violation of the tibial-femoral canal, so you get less blood loss, less risk of fat emboli, and everything's inside the operative field, so there's less capital costs and everything. So we can look at some studies done 2011, 12 with NAM and Akawa, looking at accelerometer-based navigation, and everything fell within 90% of accuracy, which gives you confidence in the navigation. So we're going to have a couple of videos here where we're going to go over the steps. I'm going to get this one started. And basically this first pin is placed at the center of the knee. You can see I got Whiteside's line on there, and we just direct that pin down the axis of the femur along with Whiteside's line. And you set your jig in place. There's an offset for this jig. I usually set it about 3. Sorry about my head getting in the way. And that's the basic beginnings of the setup. And once you get it set up, you place your 2 trackers on here, and you find the mechanical axis of the femur, and you're gonna see me go through the registration. And then this is the important part. This is using the accelerometer to track the actual to map the femoral mechanical axis. And once that's set, then you can set your flexion and varus valgus, and you're going to see me do that on this video as well with the little screwdriver. And with this implant, I want to set my flexion at about 4 degrees, and my varus valgus is going to be 0 degrees to the mechanical axis, and that's it. And you're done, and you're moving on to the next step. And then tibial prep. The tibial prep doesn't change from what you normally would do. You're basically using the same pin sites that you would use for a regular tibial extramedullary referencing jig. So I set the jig in place. You reference the center of the ACL footprint, and you put your pin in place. And all we're referencing is the offset from the jig to the center of the ACL footprint and the medial and lateral malleoli. And this get you your tibia mapped so you can set your goals. And I usually, when I first started doing ortholine, I tried to set my tibia right at 0 varus valgus, but now my goal is usually about 1 degree of varus. And there you go. We're ready to cut. So looking at my own cases, so we looked at about 140 cases before I started using ortholine, and my femoral mechanical alignment less than 3 degrees out. I met that goal 81% of the time, and with about 190 cases after I started using the handheld nav, I was accurate 91%. I was within the goal 91% of the time, and tibial alignment didn't change much. There was no significant difference there. It was 96.1 before, 96.6 after. So definitely the biggest benefit for me was probably getting coronal alignment on the femoral side. There's also benefit in getting that flexion alignment. That's something that that's not quite easy to measure on X-ray. So I didn't study that. But overall limb alignment, conventional, I was at a ½ degree of varus, and after it was 0.2 degrees of varus, which wasn't bad. And you looked at the total time it took me. Before, my average tourniquet time was 47 minutes. For the first 15, it was 52 minutes. And for all the cases after, the average fell right about 40 minutes. So I ended up going a little bit faster. When you have a small patient and the case is moving, I've had times at 24 and 27 minutes. So I don't think the navigation it doesn't add time to you. So yeah, in summary, accelerometer-based navigation can reliably result in consistent femoral alignment more than tibial. And the intraoperative feedback and flexibility is there. It's simple, it's within the operative field, it's open, you can use it with any knee system. And like I said, there's really no disruption to my workflow. And the biggest thing is this met all the goals from the hospital side. The cost was within range to get all the stakeholders in the hospital on board. So it made it easy from that standpoint as well. And that's it. Cool.
Great. Hey, thanks, Tim. That was great. Thanks for staying on time like everybody else. Orhun Muratoglu is going to speak to us next. Take a little bit of a change in where we are. Over the last 2 talks on total knee, but we're going to talk about diagnosis and classification of hip dysplasia on radiographs versus deep learning. So thanks again, Orhun. Looking forward to hearing from you.
Thank you, Bolo. These are my disclosures, and they're not relevant to this talk. And so I'm going to tell you about a deep learning method that we developed to diagnose and classify hip dysplasia. And in a dysplastic hip, the acetabulum is too shallow to accommodate the femoral head, as you can see on the right-hand side X-ray. And this can, of course, lead to osteoarthritis and may require total hip replacement to treat the dysplastic hip. Generally, the plain X-rays are used to diagnose dysplasia, and the CRO is a commonly used classification system for this. Typically, the ratio of the distance, as seen on the X-ray, distance A to distance B, determines the CRO classification. You can see the table on how the classification is done down below. Category 1 represents a mildly dysplastic hip, and the category 4 is a severely dysplastic hip. We have successfully applied deep learning for analyzing radiographs in a variety of other orthopedic applications. And in this study, our aim was to train a deep learning model to classify dysplasia on plain X-rays. This model could increase the diagnostic accuracy and automate the classification of dysplasia. And if successful, this method will require less manual labor, and there will not be any need for a skilled reader. It can be done by a radiologist or as well as by the primary care physician. It can help make surgical decisions even before having been seen by an orthopedic surgeon. And natural progression of the disease ultimately leads to total hip replacement. And we can also predict with the proper set of longitudinal data when and if the patient would need a total hip surgery. So our data came from 3 different sources, one from a prospective international multi-center study, and 2 sets of data came from 2 retrospective single-center cohort studies from Japan. We had a total of 625 AP hip x-rays and 371 in CRO1, 75 each in CRO2 and 3, and 24 in CRO4. And we had 1 orthopedic surgeon who is a specialist in dysplastic hip surgery, and 1 resident orthopedic surgeon who classified by consensus these x-rays into these CRO classifications that you can see here on this table. These are representative x-rays. As you can see from these x-rays, the quality varied greatly, making the radiographic assessment challenging. And at the beginning of the project, we thought that the variations in the quality of the x-rays, the Japanese characters on some of the x-rays, and name tags, etc., could confuse our deep learning method. But at the end, once we went through the analysis, we found that none of these actually mattered to the deep learning system. So we used a custom designed convolutional neural network, off-the-shelf CNNs as these are called, are designed for analyzing non-medical images. And these structures are not always readily applicable to medical image analysis. So what we did is we actually tuned these models for medical applications. And what we did, generally speaking, is that you can either do a shallow modification by just replacing the last layers of these models, and you can also do a deep modification by editing the deeper layers. We actually did a deep layer modification, and this way we removed the classifier layers as well as the high-level convolution layers and replaced them with new convolution layers. And this way we designed the convolution layer architecture using trial and error on the validation data set. Now, this may not mean much to you, but it actually helped improve the prediction value, but predictability of these dysplastic x-rays with the model. We use a split validation method where 80% of the x-rays were used to train the deep learning model, 10% to validate the model, and 10% to test the model. We also augmented the x-rays from 625 x-rays to 40,000 x-rays by using offline and online methods. These are very commonly used methods, by the way. For example, by 2-dimensional translation of the x-ray, horizontal flip, magnification, changes in brightness, etc. So in results, first of all, what we found is that the CNN, the convoluted neural network, learned to focus on relevant features. On the left-hand side, you see the x-ray of a patient, a dysplastic hip. And on the right-hand side, you see a saliency map. The saliency map is generated by the deep learning model. And what the saliency map references is basically, the deep learning model looks at the x-ray, doesn't know it's an x-ray, doesn't know there's a femur, doesn't know there's a pelvis, doesn't know what it's looking at. All it sees is pixels and certain assigned grayscale values to those pixels. When it goes through the analysis, it has to decide at the end if an x-ray belongs to CRO 1, 2, 3, or 4. And in making that decision, it has to weigh certain pixels more than others. So saliency map is what exactly that is. Any of these pixels that are lit up towards red means that they were used more than the other pixels in making that decision. So in here, you can see that the femoral neck is light up. You can see the pelvis a little bit. And then you can also see the lines that define the femur. So if you go to the next slide, here you can see, here we go. We achieved 80% accuracy overall in all 5 categories. When we combined, we actually did the analysis by combining normal and CRO 1 together and compare that to the remaining CRO classification 2, 3, and 4, then our precision and recall jumped to 96%. And in diagnosing dysplasia, that is normal and CRO 1 versus the CRO 2, 3, and 4, CNN actually achieved a 94% accuracy overall. So we think that that's a pretty good outcome with a limited number of x-rays. Currently, we are increasing the number of x-rays that we used in building this model so that we can also improve the prediction value that we're getting out of this model. In the next slide, I just show some representative saliency maps. And in almost all of these maps, deep learning method chose to use the pixels that define the femoral neck and the pelvis in making the decision as to which category the X-rays actually belong to. And finally, in conclusion, we successfully developed a deep learning algorithm to diagnose hip dysplasia with an accuracy of 94%. The algorithm can also classify the X-rays based on CRO with an accuracy of 80%. Currently, we're defining a borderline category between normal and CRO1. This will help us identify the onset of dysplasia with a much higher accuracy. And for this, again, we need more X-rays, and we're working hard to get more X-rays into the study. We're also implementing the arteriophylakidis classification method, which uses the anatomy of the acetabulum. And
Great.
thank you for your attention.
Thanks, Orhun. That's fascinating. I have a question for you at the end. I know there'll be others, but I want to save it because we're perfectly on time. And Stefano, thanks again for joining from the West Coast. Stefano has really been a thought leader on the technology side for AUKUS, for sure. I can tell you that he's been far ahead of the curve in embracing technology and really across numerous platforms and really a lot of different things. So he's got an expertise that is should be a treat for all of you listening. So Stefano, I defer to you.
Oh, thank you, Bo. I really appreciate you and Park City Foundation and making some room for talking about this side of technology. Up until now, we've primarily discussed technology as it's delivered to patients. I'm going to talk a little more about how we deliver technology. These are some of the roles I have in this space. And I'll talk, if it's okay at the end, a little bit about this conference we run specific on this topic. So I've got 10 minutes and 10 slides to give you just a hint of what I covered at the Digital Orthopedics Conference in about 2 days. And each of those 2 days is usually pretty packed. So this is just a sense of where we're going. So let me see here if I can move this forward. Great. All right, conflict of interest, I'll go back there a little bit. A couple of startups and also Stryker Corporation. So as I mentioned earlier, this talks about the way we deliver care, not so much about the care we deliver. So we just heard about how technology has been helping some of our top surgeons here to help deliver even better care, hitting targets and what have you. And we learned a little bit about how to use machine learning algorithms to try to identify findings on an X-ray using what is a form of computer vision. And we've done a similar project looking at this, looking at the hip fractures, and found the same thing, that the outlines of the bones what the system falls into, but that's a different topic. So we're going to talk a little bit about how we deliver care. And to that effect, this is a slide of the number of virtual visits done at UCSF Department of Orthopedics in the first quarter of 2020, obviously associated with the COVID impact. And this is something they can see us up until the early March. We had these technologies available. We just weren't using them. And with the onset of the pandemic, you can see this very rapid rise in adoption to the point where it's 50% more or less of our volume. At UCSF, we went from about 7,000 to 9,000 visits per day to about 4,500. So almost half as many, but half of those, again, were driven by the use of these platforms like this one we're using right now, Zoom, as a basic for doing it. So telehealth is one of the areas we're seeing a big uptake. Some of the other technologies, though, they're not quite as obvious and not quite as fancy, perhaps, but very, very helpful to us as those of us who run clinics or run hospitals, are technology to help us do a better job utilizing our resources. So one of the challenges we have receiving referrals by fax and then trying to grab and find patients and bring them into the office is that there's a tremendous amount of leak in that system. And this is one company that we've deployed at UCSF. And by the way, I will mention some companies, but none of these are necessarily the best companies. I'm by no means suggesting that these are companies should all purchase or buy. It's just that these are examples of what we can now do with technology. So this is Luma Health. they went up taking the referrals off of our system once they've been screened, and they did a job of contacting patients in the methodology they most like. So usually it's SMS, 95%, and we're getting something like 86% response rates when we ask for something to be done, like call the clinic to make the appointment. And you can see here the impact it's had on our empty slots in the clinics. With a massive decrease. Essentially now we simply don't have empty appointments because the system continuously tracks the appointment availability. Patients go on these virtual wait lists and get offered appointments. Another technology that you may be familiar with are the patient engagement platforms. There's several out there. This one is called Health Loop, but it's now called Get Well Loop. Nonetheless, it's one of many. They reach out to patients before surgery with emails, messages, in some case, prom score requests, and then follow them for about 6 weeks afterwards during the early and post-operative acute period. And very, very effective in managing patients' needs and questions. And in fact, the perception of patients is that the surgeon is careful, caring, and paying attention to them. They kind of feel like you're the one sending that email, and it's quite effective in answering questions that may come up and decompresses the workflow on your own staff at the office. What's interesting about this technology, it's also been out there for some time. I happen to know the CEO of this particular company. He was telling me that in the first 2 months of the COVID epidemic, they signed up 70 hospitals when it had taken them about 7 years to get about 15 systems in place. So these technologies are very much being adopted, and the patient satisfaction from these is off the charts. It's 90-95%, pretty much across all these platforms. Another challenge that I don't know about you guys, but I know I have when I walk into my scheduler's offices, the 6 of them sitting around, most of them are using paper still. Some of them are dabbling with using schedules, but for the most part, there's no digitization of the experience around surgical scheduling. And where that comes in super handy is not only in being able to instantly track your backlogs, your potential need for surgical times to meet your needs, whether or not you're in supply-demand balance, all these as reports that can be generated automatically without having to ask your EMR integrators at the hospital for data. You can get this information back directly. But if you're missing a patient or you have a cancellation, very quickly the system can actually read the charts using natural language processing and actually figure out that these 4 patients could actually fit into that slot. So your staff can very quickly backfill any cancellations. And of course, it can be used across multiple sites, so you can centralize your scheduling if you operate at multiple hospitals. And this is one very solid contender in this space, and there's several others. Another area of concern for a lot of people is the need to document constantly to the EMR. This is one of 2 major companies in the space, Robin being one, the other one is called Suki, that have done quite a lot of work at trying to be able to integrate basically an Alexa-like device in your office, listening in to the conversation, and from that conversation, creating essentially a normal note. Now, it still requires some human intervention, but I have these in my office as well, and I find it very helpful. I can even dictate straight to it, in which case the dictation is excellent, or it simply listens in and creates a note. These are on their way to being really, really good, but definitely technology is worth using. Many of you are familiar with physical therapy rehabilitation platforms. Force Therapeutics is one of them. They came in early. Another one is PT Linked. The way PT Linked worked is basically it's a smorgasbord. It's an options. You click on the exercise you want. The patient and the physical therapist gets it, so everybody understands on the same page. These are a lot easier to deal with than those sheets of paper we tend to hand out. Going a little more into the futuristic perspective of things, this is an example of what you can do with a HoloLens, where the patient gets to wear a HoloLens. If the physician is also wearing HoloLens, you actually can have this sort of holographic experience, and where you can share, you so beautifully saw a chest x-ray sort of thingy, but you can share charts and images, etc. There can be a nurse in the room as well. This is actually not sci-fi. This has been deployed in the outback in Australia to reach patients that are too far from major medical centers. Another very interesting big picture thing is the confluence of technologies. So chatbots, avatars, computer vision, voice recognition, sentiment analysis all come together in this particular video.
I can see you and hear you. And what makes me different is that I can respond to your emotions. I guess you could say I'm putting a human face on artificial intelligence.
Wow. Now, what makes this fascinating is that that avatar is listening to the tone of your voice. It's understanding what you're saying. It's using sentiment analysis to understand how you feel, but it's also linked to the camera on the computer looking at you and actually reading your face for your emotions and opinions and changing her behavior to match that. Now imagine if she also has access to your charts and able to book patients for you and to get people into your office, can answer patients' questions about their wounds or what have you. This is sort of the next generation of virtual office secretary, office assistant to support your patients 24/7, every day of the week, all day of the year.
I can see you.
So I've been interested in this space for a long time. I run a conference, DocSF.health. We're going entirely virtual. All the documentation is out there for you to see. If anybody's interested, consider looking at our website and maybe joining us for our next event. Bolo, back to you. I hope that was what you're looking for.
That's great. Thanks, Stefano. That was a great talk. I've got a couple of questions that are put aside here, and I just would like maybe Rand and Tim, you guys answered the question on the chat side, but just your thoughts about addressing gap balancing with these type of technologies. Maybe Tim, then Rand.
Yeah, Arthur Line's developing a gap balancer that integrates well with the handheld device that'll get you your information based on the implant you're using, so you can balance your gaps. From a measure resection standpoint, it doesn't change much what we would normally do, because once we got a distal femoral cut, we're back to using the Form 1 cutting block and getting our normal measure resection. And the same goes on the tibial side. If your implant needs a 9mm or 10mm or 8mm resection, that's what you do.
I was just in your flow, I guess that was a sort of a measured resection flow. I mean, it looks like you finished femur, I think. Is that right?
Yeah, I finished the whole femur, and after the femur, I do the tibia. But then you can do the gap balancing. All of these systems will have the potential to do gap balancing, and you can adjust them. But currently, it's hard. They're not. They didn't start as a gap balancing device.
All right, and then I'm gonna go to Orhun before I go to Stefano, because I've got at least one for Stefano. I probably should have more as high tech as that presentation was, particularly when I got a little weirded out at the end by the robot lady. But Orhun, I'm fascinated by your presentation. I'm going to ask you sort of a practical question, because do you think that approach? How about for something even easier, like extent of knee arthritis? KL grading. Seems like that'd be a chip shot for something, maybe for screening patients. Your thoughts on something like that?
Yes, it will be. It will be. We are actually doing a bunch of different things right now. It's basically, if you have the data, the rest is easy. The data meaning, if you have X-rays, if you have enough X-rays in each one of the categories, then it's very easy to train a deep learning model, and accuracies can be very good. The more films you have, the better the accuracy is going to be. And I'm quite fascinated by the fact that, for example, we're doing one study where we're looking at the femoral loosening on a total hip. And so we know for sure that the femur was loose during surgery. So we have the pre-op X-ray, and then we have loose and not loose X-rays. And you can get very good accuracy in picking up the ones that are actually loose. And some of the ones that, Haney Bidare cannot tell if it's loose or not on the X-ray, but the deep learning model actually picks them up as loose. So it's pretty fascinating that it actually works.
No, it's great.
Yeah.
It really is. It's great stuff. That's very neat. So Stefano, one for you, but I think everybody maybe would comment after you about the telemedicine just in general. And thanks for sharing your slide about the UCSF bump. We had a similar one here too. The question sort of around, reimbursement for it, particularly some of the longer, some of these telemedicine visits, although they're great and we certainly have increased their use. What are your thoughts about trying to get even maybe increased reimbursement for the longer, more complex ones, where it may even be have its greatest advantage in some of these harder, more complex patients? Thoughts on that?
Yeah, so there's two pieces of that. Will telehealth survive COVID? Will there
Right.
still be is the healthcare system going to try to push us back into the clinic? And as an aside, on the 29th of May, we are convening a DocSF virtual event specific to talk about that conference. We're going to have the ATA, American Telemedicine Association, CMS, Kevin Bozick, a bunch of people to say, look, how do we make sure we have these tools available to us, but at the same time, how to have reimbursed appropriately for them? Because it's been shown already that, yes, it's nice to get reimbursed and did help the adoption, but we're not getting paid enough for the amount of time required, especially the amount of time to get some of these older people set up. It's good 15 minutes before they're set up. How does that get paid for? On the other hand, there's massive savings to the healthcare insurance industry. And if you notice there's been some interesting data about with United coming back with 7% earnings this past quarter. Why aren't they putting that back to us? So the answer to your question is, this is a really interesting opportunity for us to work together, ACAS, Academy, everybody who's interested in this space, to say, okay, let's keep what's good about this, because I think, to me, the sweet spot for telehealth is return visits. That don't have to be screening care. But I need to see patients in person for the diagnostics and for some of the more complicated ones. So I think that's where you're going with that. And I think that we're all in the same boat, looking, okay, how can we make this work for all of us?
And to the group, any other comments sort of on your experience, maybe an increase of use of telemedicine, maybe thoughts about hoping to continue to use it, or maybe if it's changed your interest in use recently?
I can say I've been using it a lot in NYU. We've been using it a lot. And especially now that we have to do distancing and we can't bring as many patients to the office, it's an advantage in some ways. If I can see, I used to see 6-8 patients in an hour, and now I see 3 patients or 4 in an hour. I put video conferences in between them, or I try, and that helps seeing your patients. And some patients don't want to come in. They don't want to come to the hospital now. They're much happier. I think my only challenge with telemedicine now is x-rays. How to be able to see the x-rays while I'm doing a telemedicine, not then go seek x-rays or send them somewhere. I think that's the next thing that has to be built into it, because they not always can go to a place that's within our system to get the x-rays.
Bini, what are you guys doing around that? You've been doing telemedicine longer than probably most. Any tips?
Me?
Bini, yeah.
Yeah, the X-ray experience is, I think what you mean, Rand, is getting new films and getting them back into the system. There are technologies for that. There's no question. It's actually pretty straightforward, but most hospital systems haven't picked them up. There are technologies that allow this, but here's the interesting thing. The technology is built around a CD-ROM. Who has a CD-ROM at home anymore? So the idea was the patient would take a CD-ROM, put it in their computer, upload it to the system on the web. But unfortunately, the patients don't have the CD-ROM player anymore to do it with. So now we're doing direct communication between hospital to hospital. The PAC system are getting increasingly good at transmitting data, and I think that's going to go away. One of the important things to think about around this whole telemedicine piece is this is not a static moment in time. We were able to take advantage of the telehealth visit itself. That's based on these virtual conference builds, which are already in place. NYU had them in place, UCSF had them in place. There's a ton of stuff out there that hasn't been embraced as well, like all the sensors that people can use at home, this ability to potentially go to their home as a hologram and actually see them move around the space, the ability to potentially collect data before they come in over a period of time directly from their phone. All this stuff is currently available. It's just it hasn't been implemented. So I have a feeling that over the next 5 years or so, you're going to see a maturation of this field to the point that a lot of the questions we have will largely go away. Imaging, even a question of imaging, how much imaging do we really need? I think we're going to be doing some of these machine learning algorithms. It'll be a very strong predictive value. It'll tell you what an X-ray would look like future. You can actually may not even need more than 2 or 3. It'd be very interesting where it's going.
No, it's great. I want to thank everybody so much, particularly first and foremost, the panelists. I should also thank our sponsors. I think you've seen them represented in some of the announcements around the webinar, so thank them, and thanks for our attendees. Thank you, guys.